Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family Community Medicine at the University of Toronto. I'm delighted that our department can, together with the Ontario College of Family Physicians, continue to bring these sessions to you every 2 weeks. And I'm going to turn it over now to Dr. Liz Muggah, the president of the OCFP, to introduce the session. Liz.
Thanks, Tara. Really excited to be here. I feel like we're definitely on the cusp with the announcement coming today. We expect about the approval for vaccines. So this is our part 2, more information on that 5 to 11-year-old group for you. We've got a great panel, so some practical on the ground and also some evidence-based information about the vaccines. This is MainPro accredited and the details are there about that. And next slide, I'll just read the land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories that you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. I'm calling in from Ottawa, which is unceded Algonquin and Anishinaabe territory. Send back to you, Tara.
Thanks, Liz. I mean, we know that Indigenous peoples in Canada continue to face systemic discrimination, structural barriers that put them at risk for COVID-19. And so just a reminder that they are one of the priority groups that would be eligible for their third dose at least 6 months after they received their second dose. Next slide. Just a reminder too that, as Liz said, this is our second part of talking about kids' vaccines, and would really encourage you, if you missed it, to watch the past session 2 weeks ago, where we had Dr. Upton Allen speak about kids' vaccines together with Sophia Ikura. These sessions are MainPro accredited even if you watch them afterwards. So we won't be repeating all of the things that were said last time, although we will be continuing to take your questions. Next slide. So delighted to have a great panel today. Next slide. And I'm going to turn it over to our panelists and co-hosts one at a time to introduce themselves. Kate?
Good morning. I'm Dr. Kate Miller. I'm a family doctor based out of Guelph, Ontario, who's been fairly involved in trying to create patient-facing accessible language resources. And I'm going to talk a little bit today about hesitancy and addressing questions. Joan. Oh, and I have no conflicts to declare.
Thank you.
Hi, everyone. I'm Joan Chan. I'm a family doctor also from Guelph, which is the ancestral lands of the Anishinaabe and Haudenosaunee people, Treaty 3 lands. I am the only conflict in that something I'm paid to do is I am the chair of the Guelph Family Health Team board, and I do get paid for board related activities. Otherwise, I don't have any conflicts.
Allison?
And I'm Allison McGeer, infectious diseases from Sinai Health System with an interest in adult immunization. And you see from my conflicts that I have lots of relationships with companies that make vaccines.
Next slide. David?
Hi, I'm David Kaplan. I'm a family doctor, not from Guelph, but I will be in Guelph later this afternoon, funny enough. I'm in Toronto, and I'm the Vice President Quality at Ontario Health, and I receive salary support from Ontario Health for my job there, and I receive a stipend from the OCFP for these sessions.
Liz?
Liz Muggah, family doctor in Ottawa, and in my role with the OCFP as president, I receive a stipend and no conflicts otherwise to declare.
So I'm also a researcher and do have a number of grants and honoraria to declare. The only grant from a for-profit company is from Gilead Sciences for Hep C, which is no conflict for today. Next slide. So delighted to welcome all of you from across the GTA and beyond, which is wonderful. Next slide. as you know, we take your questions that you submit at registration to design the session, and that's what we've done this time, but we also are going to leave plenty of time for Q&A, and I see you guys have already started to put your questions in, which is wonderful. So just a reminder to put the question into the Q&A if you have it. If you see another question that you like that's very similar to yours, instead of retyping that question, please vote with the thumbs up. I'm going to prioritize answering the questions that have the most votes, so that have the most thumbs up and rise to the top. Our panelists will also try and do their best to try and answer some of the questions by typing. Please do use the chat though to share information, to connect with others. I noticed already that somebody has corrected me to say that the timing of the third dose is not 6 months, but 168 days in Ontario. And yes, this is true. Next slide. So, it's been 2 weeks since we've gathered, and already I think things are starting to change a little bit. So this is a graph, of course, of new cases in red and new deaths in blue. And we can see that we had been nicely suppressed for some time, but now that we're starting to see a little bit of an uptick, and I know many people are a little worried about that as we head into the winter months, where more people we know will be gathering indoors. Next slide. So what can we do about this? So of course, this terrific publication came out from the BMJ, just really confirming in particular the importance of mask wearing and physical distancing as important public health measures that can reduce the spread and risk of COVID-19. So we need to continue to encourage our patients to take those measures and be vigilant over these winter months. Next slide. At the same time, we know test, trace, isolate support continues to be a mainstay for how we manage COVID. And, it was great to see this announcement of trying to make testing more accessible for Ontarians over the winter months. So we've got expanded access to testing through pharmacies. So that doesn't just mean symptomatic people going in, which I know many of us are concerned about, but at the same time, many pharmacies will be distributing take-home kits and where they can also be dropped off back to the pharmacy. There's also going to be more kits, rapid antigen kits delivered from schools, PCR kits available in the offices at school for symptomatic kids and their parents. And then some holiday mobile testing blitz occurring as well. So just a reminder about these, partly because I know many of my own even acquaintances as well as patients, for example, were unaware that these PCR testing kits were available in their school offices, and it's a great way to hopefully have access soon. Next slide. So of course, the other way in which we can protect ourselves is through vaccination. And this graph from the science table, I think, really illustrates pretty clearly how those people who are most sick and hospitalized are the people who are not vaccinated. Now, interestingly, we can also see that even among the fully vaccinated group, there seems to maybe be a little bit more of an increase. And I think this is really pointing to the importance of third doses, although we're going to hear later from Dr. Allison McGeer more about that. So that's definitely going to be one of the things we're talking about today. The other thing, of course, that we're going to be talking about are the biggest unvaccinated group that we have, which are children and children 5 to 11. We're all very excited that everything is being signaled that Health Canada will be announcing today that approval for the children's vaccine. Next slide. So, this is just a sneak peek at some of the information that's going to be shared. We see here that there is some difference with the pediatric formulation versus the adult formulation. For example, the pediatric formulation is more stable at room temperature or can be left at room temperature for longer. And of course, the dose is going to be different. It's 10 micrograms versus 30 micrograms. That means 0.2 milliliters. Next slide. Importantly, it's going to be an 8-week interval between the first and the second dose. We think that's what's being signaled. We think that the reason that, there are probably a couple of reasons why this is being signaled. One is that we know a longer interval increases the immune boosting response of the vaccine, and it also probably decreases the potential for more worrisome side effects like myocarditis. I think we are waiting to find out for certain what the eligibility will be and whether that is by specific birthday or birth year. And so I think you can stay tuned today for more information about that. One last thing that I'll mention is that I know that there's a lot of questions about co-administration. So from our understanding at this time, basically co-administration is not going to be encouraged, it's not preferred, but at the same time, it won't be a contraindication. So I think that NACI will prefer that people get their flu vaccine, for example, and their COVID vaccine at different times if you're a child. But if they had gotten their flu vaccine 2 or 3 days before, for example, they shouldn't be turned away for, if they got their flu vaccine 2 or 3 days before, they shouldn't be turned away for the COVID vaccine. So it's not going to be a contraindication. So that's what is being signaled right now. Next slide. So with that little background, I'm going to turn it over to Dr. Kate Miller, who is going to just talk to us more about the conversations that we can expect to have with parents over the coming weeks. We know parents are reasonably going to put forward many questions and concerns. What are those questions and how can we address them? So Kate, over to you.
Perfect. Thanks, Tara. So I think I've been having this conversation a lot. I have a really young practice, but I suspect the majority of us have already been talking about vaccination for children in an enthusiastic and sort of empowering kind of way. All through this pandemic, we've had a group of people who are already lined up and are queued to phone our offices at 9 o'clock this morning to try and book an appointment that we cannot yet give them. And there's also going to, of course, be the group that really are going to be hard, if at all possible, to convince. And then that large middle group who have questions, uncertainties, need a little more information. And I think with pediatrics, that middle group is going to be bigger than it was with adults, just like we saw with teens. And so part of what I've been doing to try and build that confidence and get ahead of that is normalizing vaccination. We give kids vaccines all the time. So I've been talking about COVID as part of the normal vaccine schedule for at least 6 months now. Any other time vaccination is coming up at every other wild child visit. And also I think that helps parents put it in perspective that they've been vaccinating their children against things that they really haven't thought in depth about. I think the other really important thing in these conversations is to acknowledge the fear and the questions. And actually, I think those are good. And we need to have our families understand that when they're asking questions and expressing hesitancy, that makes me happy to know that they are thinking seriously about what's best for their child. They're looking for what's best for their child. And that validation of their questions and their fears really helps put their mind at ease that the information we're going to provide to them to address those questions and fears is valid and really not trying to refute them so much as support them. And then I think there's 3 main areas where I'm seeing more questions, and I think we're going to see a higher volume of questions with pediatric patients than we might have with older groups. One, the fact that kids don't really need it, that they're not likely to die from COVID anyway. Bigger questions about safety, particularly long-term safety, and more concerns around needle fear and needle pain. Next slide, please. So I'm going to try and just address those 3 challenges quickly here, with the first one being that whole he's not going to die so he doesn't need it argument. And we've heard that already with young adults and teens. It's going to be even bigger in kids. And so my conversation around that really focuses on the fact that death is not the thing we should be looking at in our target in terms of thinking about why vaccines protect children and are good for children. I would also talk to a parent about the fact that yes, the risk of death is low, but whether the risk is 1 in 20 or 1 in 20,000, if your child is that one, it really doesn't matter to you in front what the risk is. Our goal for children, of course, should be that none of them die. That there is lots of illness that comes with COVID that isn't death. It's ICU admissions, it's hospital admissions, it's things like MISC. I think we talk about myocarditis as a vaccine risk, and this is another opportunity to talk about myocarditis as a COVID infection risk. But a lot of my conversation around benefit actually has nothing to do with serious medical morbidity and mortality, but more about the impact in the family and your life if a child in the home gets COVID or is exposed to COVID. So that's isolation for the child and the family. That's more lost time from work. That's potential for lost income. That's more missed time from school. It's more people inconvenienced in the life around you. So the number of people who also then, whose child might be sent home from school, it's those phone calls that you need to make to the hockey team to tell every parent on the hockey team that their child has COVID and might have exposed them the day before. So now their child needs to isolate and be tested. So it's a lot of impact across life that really none of us want to have to take on if we can avoid. I think it's also about vaccination and what it will allow our children to do. Some of those benefits that those of us who have been vaccinated have gotten, some of that return to normal life, being able to send your child to a sleepover without being anxious about whether they're going to get sick there, potentially being able to remain in the classroom if some other child in the class is sick, fewer nasopharyngeal swabs and visit to the COVID assessment center. And I mean, I have many children in my practice who are well over 10 nasopharyngeal swabs now. So really, and then I think the other piece in this is that normalization of what we are already immunizing against from a severity of disease. And there's some good charts and tips out there that we can drop into the resources, comparing to outcomes with things that they are already vaccinating their children against without hesitation, like polio and chickenpox, that have similarly mild death outcomes, but have other impacts for society. I actually don't talk a lot about benefit to community with many families because I think that is not as big a driver as benefit to yourself and your family, although that's obviously a piece of it. But the one benefit to community piece that I also often bring into the conversation is around exposure of others within your close-knit circle. So I have two families that I'm aware of where a young adult with COVID infected the grandparent with COVID and the grandparent died. And so I don't actually try to appeal to fear mongering much, but that kind of also thinking about how you would feel if your child was the one who infected someone else, your child came out okay, but your child, the other person, did not. Next slide, please. I'm not going to talk a ton about safety and long-term effects because I think Dr. Upton Allen really addressed a lot of these things 2 weeks ago. So if those of you who are looking for more information, lots of the resources we've attached to this as well as that talk are great places to turn to. But I think it is fair for parents to have more concern about safety. And so some of the big ticket things that I'm going to talk about when I'm having that conversation, the thousands of children in this study, and that they're now approaching 2 million doses given to children in the US. So we actually have a lot of vaccine given in this population very quickly already. That vaccines, by the very nature they work, and we know that not just from this study, this vaccine, but vaccine science in general over more than 100 years, that long-term effects are not the thing we should be worried about, because by the way vaccines work, they're in and out of your body quickly. What lasts in the body are antibodies. We've got lots of those already. And that we have really robust post-marketing surveillance things. So if there's going to be a signal of safety that's a low occurrence risk, like we saw with it and myocarditis, we're going to see that here. Next slide, please. And then just so these resources, they'll be in the resources, but I think we're all familiar already with the sick kids one. Max the Vax is a great new resource that's come from a group of pediatric organizations that's hosted by the Ontario Association of Children AIDS Society. They've got fantastic resources for both parents and children, including some great links to some things in social media and other places on the web. So if you're looking for a one-stop place to send families to look for information for kids, this is probably the one I'd send to. We're all probably familiar with the Sick Kids Vaccination Line, which has been doing consults for 12 and up, and one would assume that that will open to consults for age 5 and up as a booked phone appointment. And then lastly, next slide, please. This resource next slide, please. This resource hosted on the University of Waterloo website. So just a shameless plug for work that I've been involved in, working on a Q&A for COVID mRNA vaccines for children, as well as a one-page get it now or wait later, and some post-vaccination resources. Next slide, please. And then lastly, just to touch briefly on needle fear and pain, I'm not going to go through a whole long talk about how to address this because I think that's really more than we have time for today, but only to say that again, on that acknowledge front, we should be thinking about the fact that parents are reluctant. He just had his flu shot. It was really traumatic. Do we have to do that to him again? Our kids get enough needles. And I think that's because a lot of kids' needles experiences, as you see in the photo, two people holding down a screaming child, telling them it's okay when clearly the child does not think it is okay, and vaccinating. So there are actually a lot of great resources out there, again, to direct parents to, or to look through yourself if you're going to be giving these vaccinations, to think about how to do it better with less trauma for our kids. So the CARD system, which is comfort, ask, relax, distract, has a really good structured approach. Immunize Canada has some good resources to send out to families in terms of preparation. So thinking about conversations 2 and 3 days before, conversations the day of. Sick Kids, for instance, has a video which steps through what to expect at your appointment, so the child has a sense of all the steps that are going to happen before they get the needle. And then the last one I have there, I put in just as an example to remember that there are lots of webinars and videos out there for parents. So this is one based out of University of Guelph, because we're having a bit of a Guelph theme today, which is a webinar coming up in December talking through pain management strategies for immunization. And I think that's it for me.
Thanks so much, Kate. I think people really appreciate the approach that you have been outlining. And just a shout out to Dr. Amanda Adams, who's the family doctor who started Max the Vax back out in Markham Stouffville Hospital. So congrats to her, and there are stickers I think that you can order for your clinic to let people know about that. I think there've also been some nice comments in the chat, just so, you know, basically agreeing with the kind of the approach that you're suggesting, Kate. Carolyn Donsky saying that, you know, she's finding a really helpful aspect of talking to parents is the benefits of mental health and more access to activities in terms of being vaccinated. And Andrea David was saying how she draws a parallel to the chickenpox vaccine that most children do fine with, but now it's a normal part of our vaccines, and we know prevents some really serious outcomes. So I mean, I wanted to just take a moment to answer also a few questions in the Q&A. I wanted to let the audience know that I'm going to bulk the questions that relate to childhood vaccination right now, and we'll deal with the ones related to the booster in a little bit of time, because I know that there's more about the booster as well. So one question that's been asked, and I don't know, Allison or others, if you have information about this, but Denise Bose says, as of yesterday, the US has vaccinated 2.5 million children in the 5 to 11 age group. What rate of myocarditis is seen so far?
So I can walk out on that limb. You know, I think it's important to remember that it's a couple of days after the shot that you get symptoms, and another couple of days to present, and then somebody has to diagnose it and validate it. So we're just not far enough in yet to have any official data. On the other hand, you know, everybody's watching really carefully. And the longer we go without somebody posting a note on Twitter or there being some discussion about it, the more promising it looks. But I think we're going to have to wait another 2 weeks at least before we see the.
I think Allison
maybe I'll just add. So if you think about the rate of in young men 16 to whatever with Pfizer, it was about, and Allison probably can correct me, but it was around 30 to 37 per million doses. So if they've given 2.5 million doses, you know, we'd expect some signal in the next couple of weeks, to Allison's point, if there is a signal around myocarditis. But again,
we're also expecting the number to be lower, just because myocarditis is less frequent in younger children. So it's just going to take more time than you'd like. It can't be helped.
And I think that the peak, we know already from the evidence that's out there, the peak is around age 16, and it goes down from 16 to 12. So that's part of my messaging to parents, is it's almost certainly going to keep going down from there.
Yeah, and so I think Dr. Upton Allen went through some of that data in detail in our last session and reminded us that there's physiologically a lower risk, it seems, but then also the fact that the dose is a third of the adult teen dose also lowers the risk as well. So thank you. So I think another question that's come up is around consent. How do you approach consent to receive vaccine in kids? So what if a child would like to receive, but a parent declines, or a child says the parent approves, but is unable to present due to work obligations?
So I think we're going to see that less obviously in the 5 to 12 group, because they're a group that are going to have a hard time getting to us without the benefit of an adult. But if we're thinking that older range, the 11 to 12-year-old, I'm approaching it the same way every time I'm seeing a child in that age, which is we have mature consent law here. I think it'll be interesting to see what happens, because there is some suggestion that within the rules we're going to require consent for this age group, which was not true in our teen group around it. But if a child can express to me why they need the vaccine and risk, clearly that's not going to be a 5-year-old. It's going to be an exceptional 12-year-old, to be honest. But
so to that point, and I think this came up last time, but I think it's worth asking again. If an 11-year-old receives the 5 to 11-year-old first dose, what dose should they receive when they are 12 years old at the time of the second dose? I don't know so I think we're waiting for NACI recommendations on that. But I don't know if anybody has anything they wanted to speak to about it.
To me, the important thing to recognize is NACI is going to try to make a recommendation that makes things simple and efficient. But in the end, it doesn't matter whether a 12-year-old gets the childhood dose or the adult dose. They're both going to work. So, NACI will tell us either today or Monday. And then we'll try to do what NACI says, but it's not something that people should be spending a lot of time worrying about. It really, from a science perspective, doesn't matter.
All right, so I'm going to ask Brian to just put up the slides again, because I just wanted to speak briefly. Our slides have lots of resources, and we're going to share that to you. But what I wanted to speak briefly about, have Liz, you and David maybe speak briefly about, is kind of the rollout plan and what we know about it so far. So Liz, over to you to tell us a little bit about what we know.
Yeah, thanks. So, again, just to the point that we've been making, so some of this has not yet been announced. So I think just stay tuned. We'll have lots more information, but this is the most recent info that we got from the ministry. So I think the first to point out is that there is a lot of vaccine available. So people don't need to worry about whether there'll be enough supply for kids, and actually a pretty ambitious plan there. If you can see, the hope is 659,000 doses, first doses by the end of December. So a real push to get as many first doses in as possible early on. A mixed strategy, again, you can see on the left, with a focus on the mass clinics and school-based. So the guidance to the 34 public health units was really to do their very best to include schools. So most, but not all, public health units have already done that, but that was a part of the guidance they were given. I think the mass clinics will look a little different, so more community-based, smaller, quieter space for families, ways to address kids with special needs, anesthetic cream available, all those types of things. You can see primary care there at around 8% is the estimation. So just channels are definitely open if you're interested in vaccinating in office. You may have already heard from your public health unit about that and opportunities for that. That's definitely welcomed. Or if you want to support the pop-ups or the mass clinics or the other efforts that the public health units will be leading. So the plans are all sitting there and ready for in the public health units. I think Toronto and Ottawa have released theirs. And if you're not, and although those are not in every unit, we haven't seen that in every public health unit. I know they've been written and approved, and everyone's just waiting for this announcement today, and all of that will come flooding out.
Thank you.
So I think the only thing I would add is those probably about 140 odd practices that have been ordering vaccine in Toronto received a message early or 2 days ago, I think, about ordering their first shipment of pediatric doses. the orders had to go in yesterday at noon. So if you missed it, it doesn't mean that you can't get the vaccine. It just, you won't get it in the first tranche, but is meaning about a week after it's approved. But as Liz suggested, we don't expect there to be any supply issues. Just from a logistics standpoint, for people who are planning to offer it in their practice, the vaccine comes in 10 doses per vial, not 6 doses per vial. It can be refrigerated for up to 10 weeks. Once it's reconstituted, you have 12 hours to use it. And then the only thing that they're also asking is, just because of supply issues now and demand, going back to trying to minimize wastage. I know that the message has really changed in getting, the last mile. If you have somebody in your office, don't hesitate to waste vaccine if you can vaccinate them. But with the pediatric doses right now, the message is really try to minimize wastage as much as possible in the short term.
Thanks, David. So we're going to move on just to that. It's a great segue to talk about how we as family doctors can get prepared to give the vaccine in our clinics, and what are some of the things we need to think through, and what are some ways in which some of our colleagues have been planning with public health. So we'll go to the next slide, Brian, and I'm going to turn it over to Joan to walk us through a little bit of what she's been doing in Guelph.
Thanks, Tara. My goal for my portion of this talk is for anyone on this who has been doing planning and trying to deliver COVID vaccine in their office and is struggling. I'm hoping this will help encourage and give you frameworks of how to do it in a less stressful way. Also, for those of you who are considering and thinking maybe we can add it in, but I don't even know where to start, I'm hoping this will help you do that. And I also want the message to anyone who is like, I cannot, I will not, I am overwhelmed, I will not deliver vaccine in my office. I also want to tell you, you are a highly valued primary care clinician who is doing everything you can, and that is wonderful. So I don't want this to be like, you got to do it like me, okay? So I want to tell you a bit of the story of how I came to doing a lot of COVID-19 vaccine planning. I've had vaccine on the brain all year. I had a pandemic baby in July of 2020, and so I had a lot of anxious energy coming back to work in January, and decided that my way to feel less helpless about the fact that my kids won't be able to be vaccinated still for a while because they're daycare age is try and get everyone else around them vaccinated. So that's been my energy of going into this work. Something about the background of the Guelph area that's interesting is the Guelph Family Health Team is very large. We have like 102 physicians, 95% of primary care comes through the Family Health Team. So just as a context of how this may be different from your community. So far, the Guelph Family Health Team has been involved with vaccine planning in depth. We helped partner with the University of Guelph to do a mass vaccine clinic that delivered over 82,000 doses over the course of 5 months for adults. We also were our particular clinics, and there's actually over 22 clinic sites that are associated with our FIT. We participated in the AstraZeneca pilot, and in that initial pilot even delivered 2,500 doses that way. And many offices continue to deliver, though some may have been slightly traumatized because AstraZeneca was not the easiest vaccine to give. In my office alone, I'm in an office with 5 other doctors, and we have given 941 vaccines in our office, AstraZeneca, Moderna, and then a couple vials of Pfizer for the holdouts who said, only if it's Pfizer and only if you give it. We've done it a couple of times as well. So I do know a lot of what I'm talking about. And I do want to just do a mini brag. I know my number is 1636. That's how many vaccines I've put into arms. So I don't know if you know your number, but that's kind of a fun thing to know. So next slide, please. So in terms of all that background, we were then asked by our public health unit, actually, they had a strong belief that the 5 to 11-year-olds would be best served if the majority, if not all of them, were given their vaccine in our offices. Very complementary because, we know our patients best. They're already used to getting vaccines in your office. So the question that our public health unit asked us is, how can we support you to deliver it in our office? And the answer we gave back is, we cannot, because of all the things. And we can talk a bit about that. And so instead we met in the middle. Similar like to what we did with U of G, but now public health is our more direct partner. We are using public health leased space in our local mall. So people can check in and then go meet Santa and then come back for their vaccine appointment. There's other features. It's big, but not super big. There's privacy shields for kids. So it's an ideal place for kids, in my opinion. And then it'll be the fit staff as well as physicians billing H codes who actually do the immunization. So that's what we're bringing to the table. And I don't have to go through the rest of these details, but I'm like a detail person. So I like showing that to people who are also detail minded. The last point is the most important point, which is that in every meeting I was involved with planning for vaccines for kids, I said, we have to have stickers or coloring books or clowns or something. And so I am very proud that we are planning to give all the kids loot bags. And it's probably my proudest accomplishment about this particular plan. Next slide, please. So you might be listening saying, must be nice to be you, Guelph. Like, that's not what we have going on in our town. And I'm not sure how we could do it the way you've, just mentioned it. And that is fine. I think it has to be individual to what you are able to offer and what your community looks like. So the next 3 slides are just talking about a framework you could use to hopefully help make it a little bit easier. So when we think about vaccine planning, often when our public health units coming to us or the ministries coming to us, they're coming with the urgency of the big math. So in Guelph, apparently we have 400,000 boosters to give over the next 4-ish months if everyone becomes eligible eventually, and then 12,000 kids and 7,500 babies. And it's like, that's a lot. So then most people say, no, thank you. I cannot do all of that. And the good news is you can also have a small math mind. 1 vial of Pfizer is 6 doses, 10 doses for kids. 1 vial of Moderna is 14 doses or 28 boosters. Do you think you could do 1 vial's worth of one of those, whichever one you want? You get to decide once a month. Could you do it on a day that your on-call clinic's not as busy, a day that it's not as busy in your office? You may have already actually been doing a bunch of flu. Could you kind of keep that extra nurse that you already hired for that going if you have had the capacity to do flu clinics, which I know not every office has. So this is, what could you do? And it's fine if the answer is 0. It's fine if the answer is 1 vial. That is still 6 more humans, 10 more humans that are further protected against COVID-19, right? And then for me, I need to understand what's my underlying why. Why am I adding this extra thing on top of the fabulous complex primary care that I'm already doing? Like, immunization is not top of our skill bucket in terms of primary care. We do a lot of stuff that's more complicated and requires more of our brain, but it does still have this planning in it. So what's our drive? So these are the ones I've used in case anyone wants to borrow them for themselves. So this is how I do my part to move us beyond this pandemic, which I'm very much over, as I'm sure you are too. I want to stop saying COVID a million times a day. It felt worse for me to watch from the sidelines, and that just tells you what my personality is, and maybe yours is similar. I do know how to do this, and I can contribute my knowledge and skills. We do know how to give vaccines in general. There's lots of this that we're not learning fresh. There's new elements that make it daunting, but we do know the core elements of how to deliver a vaccine in our office, right? And my latest one I've been practicing is I'm creating something amazing with my community. It's an opportunity to actually feel more connected and feel like we're in this together. Next slide, please. This one, I'm not going to list it, but just in case anyone is coming to you being like, well, why can't you just give them like the flu shot? Just they come in for their PAP, you give them their booster. Isn't it easy? This is the slide for why. If you have figured out how to do that, email me and I want to know how you do it without wasting so much vaccine. Because you could draw up 6 doses at the beginning of the day and hope you give them by the end of the day. I'm just not okay with operating that way, but I'm interested if anyone is really like, yeah, we offer it to every person who comes in for their PAP. I'm curious about that, because these are the reasons I think that is not the ideal way. It's just a more difficult vaccine because of how quickly it expires once you puncture a vial, So next slide, please. And so if you're now thinking, okay, yes, I have already been doing planning, but I'm feeling overwhelmed with this element, or you actually haven't tried doing COVID-19 vaccine in your office yet, but this is making you interested in trying. These are the components. It fits on a slide. These are the things that's good to have a plan to try, and then you can try something different the next time, right? And a lot of the elements are actually optional. So providing vaccines to each patient who comes, providing vaccines is not optional. The receipts are optional. You don't have to print them for everyone. You can find another way, or you can let them look it up on the website. You don't have to document in COVAX in the moment. You don't have to have different people doing the check-in and documentation and checkout. No one like comes and arrests you if you just document it all at the end of the day. And there's a simplified way that you can do it that involves less checks, especially for boosters. They've already actually gotten this twice. You don't have to ask them all the screening questions. They already got it and they survived, right? So thinking more practically about it. And we in primary care know what's clinically relevant versus the rules. So even like the co-administration with flu and stuff, especially for boosters, for adults, it's totally allowed. And for kids, like you'll know which parents will be fine with it and which won't, right? And I'm just going on a limb and saying it. The billing codes I put in here and gave you some math. So say you decide you want to like go in on this and you have some space, you have a day where you want to like do your COVID-19 vaccine clinic once a month. If you book 2 patients every 5 minutes, you make $446 an hour. So I think you can kind of do the math of if that works for you in your setting or not. And I don't know if it does for you or not. And I think you would not be able to do this with kids. I don't think it's realistic to book 2 kids every 5 minutes. But say you had like a bunch of adults and then you did 1 vial's worth of kids, like 10 kids in a day. That's 10 more kids that are protected against COVID-19. And you can save that for the special ones that are never going to the mass clinic, right? You don't have to plan this for tomorrow. You could plan this for after in the new year. That's when you could start, right? All right, next slide. And then actually the next slide after that, these 2 slides are here just to say the other element that we have to remember is that we are vaccinating humans. That's what primary care is good at. We know our patients, we know their stories. And so we're giving vaccines to people we know and love. So we're gonna have loot bags, baby, or we're gonna have stickers. We're gonna have something that's gonna make it more personal. And even if it's just for a small slice of your whole patient population, that is super valuable. So next slide is my last slide. The last thing is just, you're not alone. You can email me. I'm good at a problem-solving vaccine. I obsess about this stuff too much. So please email me if you're like, I just can't figure this out. Like, please do. I've been running this free Zoom education series, and it's a really janky website because I just made it myself. But we've had some vaccine-related topics, and we have one coming up that's about needle phobia, promoting that University of Guelph workshop for parents. And so please feel free to listen to those YouTube videos or sign in for the Zoom if that's helpful to you.
Thank you, Joan, for sharing so many practical tips and really bringing it down to what each of us could do, despite our, with whatever resources we have. I will say that the chat is really making me smile this morning. Everyone is really, first of all, loving that you acknowledge that, this may not be for everyone. And if for those of people who are not doing vaccinations and focusing on comprehensive primary care, you're doing a lot. And at the same time, so many people just loving the loot bags and recommending that, Santa give them out. And people being, I think, just inspired by your energy, Joan. So thank you so much. So I'm going to actually, maybe Brian, why don't we go right to slide 40, which I think is the slide for Dr. McGeer. And I'm going to turn it over to you, Allison, we're going to switch topics now to the booster doses for the last little bit of our session. And because I know there's a lot of remaining questions about that. And we have a big role to play as family doctors for that as well. So Allison, I know there were a couple of slides that you wanted to speak to, and then there are actually a number of questions in the Q&A that I want to get to as well.
Yep. Thanks, Tara. So a couple of things. This slide is up because in a number of hospitals, people have become concerned that many immunocompromised patients have not yet had their 3rd doses. And it seems to me that one of the things that we've been so worried about immunocompromised patients responding to vaccine that I think we've kind of internalized the fact that this vaccine doesn't work well in immunocompromised patients. So I wanted to put this slide up from the MMWR a couple of weeks ago, just to point out that these vaccines are actually very effective in immunocompromised patients. They're not quite as good as they are in the rest of us, which is like 95%. But even in organ and stem cell transplants, in the worst circumstances, they're still at least 50% effective. And that's okay. That's well less than perfect, but it's still really good. And so this is just an encouragement to people to please to remember that immunocompromised patients do respond to vaccines, and they do need, and they will respond better to their third dose than their second. They really do need them. And obviously, getting to them is a little bit complicated at the moment, but it's still really important that we're delivering them vaccine. Next slide. Okay, and then there were a number of questions in the chat about the benefits of a third dose. So this, I've seen 3 pieces of data now, 2 from Israel and one that was just been available in the last couple of days from a study called REACT from Oxford in the UK, that look at vaccine efficacy against any infection, 3 versus 2 doses. In the Israeli study, the protection against serious disease is a little higher than that, so in the range of 90%, but it really does look like third doses are very effective at reducing not only severe illness, but also any infection, even asymptomatic infections in people. So that doesn't alter the fact that we're still seeing very high levels of protection in young, healthy people with 2 doses of vaccine against serious illness and death. So, I think a lot of healthcare workers have questions about whether they should be getting their third dose or whether we can be giving it to people in Africa who need it more than us. So I think thinking about third dose for healthcare workers, the benefits of third dose for healthcare workers are, first of all, that it does reduce severe illness by 1 more notch. Okay, not a big deal, but 1 more notch. It definitely reduces less severe illness, and there's a good reason not to want to, feel miserable for a week. It's okay to want to be protected against that. Probably more importantly, because it reduces asymptomatic infection and minimally symptomatic infection, it's also going to reduce your risk as a vaccinated person of being infectious and being at work or out because you're pre-symptomatic or not symptomatic. And so there is a direct benefit to our patients for those of us who were vaccinated getting a booster dose. And finally, yes, we want vaccines to go to other countries, but your government is committed to protecting you. The vaccines are in Canada. They're not going to move anywhere. You as an individual refusing your vaccine because people are not being vaccinated elsewhere is not, unfortunately, going to help the rest of the world. What will help the rest of the world is a slide that Tara put in later on about donating money to Oxfam. So I think, the positive thing we can do is to support vaccination in other countries by donating money to the people who need it to deliver vaccines in other countries. And I think it's probably not a good reason at the moment to turn down a third dose of vaccine when they're coming. And I think there's one other thing that I said I was going to answer live in the chat, which is I just hit the wrong button, sorry, which is about third doses and reactogenicity. The data from Israel so far, which is all I've seen, and other people may have seen other things, suggests that actually third doses are a little less reactogenic than second doses rather than more, which is nice.
Thank you,
Thanks, Tara.
Maybe I'll just go to the next slide because I'll just remind people about the eligibility. So these are the people who are eligible again 168 days after their second dose to receive a booster at this time. I think NACI has recommended that ultimately those over 18 should receive one, but this is going to be staged in terms of the order in which it's opened up to people. Next slide. Just to flag here that there's been some change in the guidance saying that if it's for healthcare workers, the third dose, you could consider having an observation period of as short as 5 minutes if that's required in your clinic. So we've kept the full wording here from the guidance, and you can refer back to this. Next slide. And then I think these are again the list of people who are immunocompromised who qualify for the third dose, and that's regardless of age, and it's regardless of the timing of the second dose, I think. So I just want to confirm that with folks. I think it just says the last dose and third dose should be at least 56 days, which is about 2 months apart. So it's not the same 168 days as for the others. So this is confusing to keep in our heads. And I will say myself, I look at a cheat sheet much of the time nowadays when I'm trying to understand if one of my patients is eligible. Next slide. I guess, I don't know, Allison or Liz, if you wanted to speak to this, but I think these were some common questions, Liz, that you've been getting at the OCFP.
Yes. So, I mean, I think that one of the questions that we were seeing in the chat is like, when are we going to get boosters for everybody else? So this is as much as we know, is that the provinces made clear that starting January 2020, that will go out to the general population. So that's to come. Exactly what that will look like, we don't yet know, but I think we can expect that. Some pieces here about, obviously you can use either Moderna or Pfizer. The full dose is for those who might be a bit more immunosuppressed or a bit at higher risk. Otherwise, for Moderna, they're getting the half dose. And don't worry, tell your patients not to worry which is the dose that you're getting. It does not matter. So those might be some of the things I would say. There was a bit, there were other questions in the chat around third doses and specific populations and eligibility. And I honestly, if it's a really specific question and it doesn't seem, you sent somebody and they weren't boosted and you're not sure why, I would just be in touch directly with your public health unit. I don't know if it's just a glitch around it has to be that exact 56 days or 168 days, or you actually can't put it into the system. Maybe something as simple as that. But so I don't know if there's anything more that you wanted me to say on that.
So no, that's great. And I'm so Brian, and then maybe go to the next slide and then I'll do a few more questions here. So, this is just what I mentioned, that there's if you are feeling guilt about getting your third dose or your patients are, you can always give money. I think one of my colleagues also reminded me that, ultimately it's not for us as individuals to feel guilty. It's about us to try and push our governments to advocate for patent release so that the vaccines are available to be manufactured by others in low-income countries themselves. So there's lots of ways towards global vaccine equity, and us foregoing the third dose is not going to help with that, unfortunately. So I'm going to end slides there and just go to a few other questions. I know that there was another one you answered in the Q&A, Allison, about what is the evidence for long COVID in people who have been fully vaccinated? And I wonder if you could just speak to that orally.
Yeah, I think it's mixed so far. The problem is that long COVID is complicated and heterogeneous, probably. Some of what we're calling long COVID is just people taking a long time to recover, particularly from ICU stays. Some of long COVID looks like sort of a specific immune reaction that has occurred after other diseases that we don't completely understand. So because of that, it's really hard to make conclusions about whether people have long COVID, because it doesn't really have a cohesive, diagnostic tests. So there are some American studies so the first thing about long COVID is if you get vaccinated, your risk of COVID goes down. If your risk of COVID goes down, your risk of long COVID goes down automatically. So yes, if you get vaccinated, you are less likely to get long COVID. If you get vaccinated and get breakthrough infection, what the risk of persistent symptoms is different in different studies. So there's one UK study that says there's no difference in long-term persistent symptoms. There's at least one American study that suggests that the reduction in long COVID in people who get COVID is at least 50%. So I think that that's still open. There is some evidence that the risk of persistent symptom goes down, and that is congruent with severity of illness overall decreases. So I think where we're going to end is that your risk of getting long COVID with a breakthrough infection is lower than with an initial infection, but there's still the data is not yet completely consistent.
Thanks. So a few more questions. I think people are I think a number of patients have asked whether they should get the same vaccine for their booster or mix it up, and whether mixing it up confers an advantage. I don't know if you have an answer to that.
I don't think it makes any difference. If you're immunosuppressed, if you're over 80, Moderna does get you better antibodies than Pfizer, and there may be some advantage to asking for Moderna, but in any other circumstance, it as far as we can tell, it makes no difference which mRNA vaccine you get. Whatever is there is good.
Okay. And what is the rationale or evidence for using only half a dose of the Moderna for the third dose?
It's about saving antigen, right? If you use half a dose, then you get to make more vaccines and more people get vaccinated. But really, it's about you get this really powerful antibody response to Moderna vaccines in particular, and you only need half a dose. It may be true that teenagers and people aged 20 to 29 don't actually need a third dose at all. But you get such a boost in immunogenicity from Moderna vaccines that people looked at it and said, there's no reason in most people to give 100 microgram dose when you get such a good response to the 50.
And then there's also some chat about when does immunity wane? I don't know if you could speak to that, Allison.
So it's a gradual process that I think depends on how old you are and how frail you are. You can see, so in residents of long-term care, you can see substantial antibody declines at 4 months, greater in Pfizer than in Moderna. And Jeff Kwong's data from ISIS in that circumstance suggests that by 6 months, there's a substantial reduction in protection from Pfizer in that really particular, very frail group of people. In the rest of the ISIS data suggests that at between sort of 6 and 7 months, which is as far out as we can get, that there's some decline, maybe some decline in protection against disease in over 70s, but people who are under 70 are still fine. There's some data from Dubai that says that by the time you get to 9 months, your protection against mild disease is waning significantly, but your protection against severe disease appears to hold up. So, I think the answer is it's a long, slow process and the younger you are and the healthier you are, the slower the decline is and the longer your protection lasts. I think that's why we're talking about third doses for most people sometime in the spring, because the assumption is that we may all get to a stage where we need boosters. But I'm not sure that people under 30 need a third dose as a primary series. I think we're going to have to wait and see what happens.
Thank you, Allison. So, in terms of indications for third dose, I think Lisa Hicks asked a question about children and youth who are immunosuppressed. I believe they are included in the third dose recommendation. I see Liz nodding there and Kate nodding as well. So absolutely, those 12 and over are included in those recommendations. I noticed that there were some questions about teen girls' menstrual cycles being affected by the vaccine. So that was Lenore Zhu who asked that. And I know, Liz, you answered it, but I think it's worth actually just speaking to this question. So how do we address this issue? I have one girl who's become amenorrheic since her vaccine and another who had heavy and prolonged periods following her first and second dose. I don't know, Kate, I know you also wanted to answer this question.
Yeah, I would just say that, again, this is back in that acknowledge, normalize, right? We already have this understanding that when our body is stressed, we get our periods go irregular. That's well accepted by most women. I had a wonky period, but I was really stressed that month. This is just a way, and that's how I describe it. Your body's energies were diverted to something far more important. It threw things off. They'll get back on track. There's no evidence that having an irregular period is going to affect long-term fertility, because I think it's a really big concern in parents for their young children is fertility concerns.
And they're the first study of looking at fertility with mRNA vaccines is actually out. It's from the AstraZeneca vaccine. and you'll know that people are not supposed to get pregnant when they're in a study with vaccines or medications, but people do. Okay, it just happens. And in the AstraZeneca, I'm wondering actually if the Pfizer Moderna studies haven't been published because Pfizer Moderna don't want people to know how many people got pregnant in their studies, because you're supposed to stop people from getting pregnant. But in the AstraZeneca study, there is absolutely no difference in people getting pregnant, whether they got the placebo or the mRNA vaccine in the period of time after they get vaccinated. So, it's not that we were expecting a difference, but it's really nice that people are working on actually getting those data out, so that we know that there's no immediate impact on fertility. It's really hard to imagine there's going to be a long-term impact if you can't measure an impact in the first 6 months.
So I can't resist asking maybe a couple questions and then we'll close off. So is there, Kate, you wanted to talk about whether there's data on long COVID in kids? I think that's also important to answer.
Yeah, I think Allison already addressed part of that, but the data that we have out there for long COVID in children ranges a really, really wide range from about 4% in the lowest studies to 25% in the highest studies, which again, in that I'm often making that parallel to mono as something that people understand as prolonged symptoms that may completely recover. And I think that fear of what if they don't completely recover is another kind of reason in that motivation of why kids can benefit.
Great. And then I'm going to, last question will be the Jennifer Whalen's question, which is really about, we're seeing this uptick of cases in Europe. And there, the majority of the population did get it at a 3 to 4 day interval. What happening in Europe likely to be in our future in the coming months? And I know that's a tough one, but I know it's on a lot of people's minds.
From my perspective, where the R naught is above 1 now. And when the R naught is above 1, there is only one direction that cases go. And we still have enough unvaccinated people that we cannot tolerate an increasing number of cases. Remember in the first 18 months of the pandemic, we infected about 5% of the population. We still have 15% of the population, adult population, unvaccinated. And we cannot afford to have more than 5% of them ill in a year without overwhelming the healthcare system. So we need to get the reproductive ratio back down to 1. And what that means is going back in October, before we took the most recent step, in October, our reproductive ratio was below 1. So if each one of us goes back to what we were doing in October, plus a little bit, okay, you can get away with a little bit more. We just can't get away with what we're doing now. I think it was so good for so long. We all got a little carried away. People are having potluck Christmas parties, and we just need to dial it back. It's not lockdown. It's just dialing back to October. And if we can all dial back to the 3rd week of October, then Christmas will be good. But I'm really worried honestly about the rate of cases increasing. We do need to do that in order not to have a totally miserable December and January.
Thank you, Allison. Really appreciate those remarks. So Brian, I wonder if you could just pop up our end slides. Just wanted to highlight for people, I know many of you are still having conversations with those last mile folks, people who haven't agreed to the vaccine yet. And this study can help you with that and help you with reaching out in a tailored approach to your patients who've still not gotten vaccinated but are eligible to do so. So please, we'll circulate the information with the slides after the talk. Next slide. I am really delighted to share that as we put together these wonderful COVID-19 vaccine modules together with my colleagues, Noah Ivers, my pharmacist that I work with, Brenda Chang, and many others, and a fantastic behind the scenes, Olivia Neal, who pulls them together. And we've added a new module for vaccination in children, which we just released. So please do sign up for the modules if you haven't, and if you have, just the same link, just refresh, and you should be able to see that new content. And we'll actually be adding some of the snippets from today to the modules as well. Next slide. Liz, do you want to talk about this special session that's coming up?
Yep, thanks. So this is next Friday, 8 o'clock. So this will be a session open to anyone who's involved in vaccination. So nurses, pharmacists, physicians. It's going to be a great session with Dr. Kiran Moore, Dan Warshevsky, also public health specialist. So really the details after we have the Health Canada and the NACI announcements and the plans are actually rolled out, an opportunity in kind of town hall format for you to get all that information. So stay tuned. We will, more information will be sent out about how to register for that.
Thanks, Liz. And so we will reconvene in, so next slide, and we will reconvene on December 3rd for our usual session. I'm delighted that we'll have Dr. Janine McCready there so that we can continue to answer questions about the COVID vaccine in kids. But also I know there are other things on your mind, so please do, when you register, provide, or when you actually evaluate the session, provide what topics you want to see on the December 3rd call. That really helps us to plan and know what speakers to invite. If you have suggestions for people who you think are doing amazing work in your region, we want to hear them, because we always like to profile people from different regions, but sometimes it's, you know, our networks only extend so far. So we depend on you to recommend people. So tell us in your evaluation what you want to hear about on December 3rd, aside from the kids vaccine, which we will be talking about. Please do check out the video and all of the resources from the session on our website. Our team is really good at usually posting them on the same day, so they should be there end of day for you to review on the weekend or share with others. So thank you again for all you're doing. I know everyone is working hard, and today is an exciting day. Enjoy your weekends.